Hello, this is Blake Clutter, and this will be a review of vascular neurology for Step 1 using a couple cases. So these are two different patients with two different imaging sets. On the right is a CT and on the left is an MRI. So the question is, from the imaging, can we detect what kind of deficits these patients might have? So to answer this, we need to know what artery is infarcted, what the vascular territory this artery serves is, and what functions this territory is responsible for. Here's a 3D model of the internal carotid artery and the anterior cerebral artery, and that little orange dot is the anterior communicating artery. From the lateral view, you can see the smaller arteries that the ACA splits into. The closomarginal artery perfuses the superomedial cortex, and the pericallosal artery gets the deeper structures in the midline. Okay, so I just gave away the artery that was blocked, the ACA. We still need to know what areas of the brain are affected and what deficits this will produce. This is the view from the top of the brain, showing what is perfused by the ACA, MCA, and posterior cerebral artery. Here's a lateral view, and a lateral view with a sagittal cut to show deeper brain structures. This is an image of the brain showing where in the motor cortex the different parts of the body are controlled. The sensory cortex is similarly organized. As you can see, the legs are more medial and the face is lateral. The ACA supplies the medial cortex, so patients with an ACA infarct often have weaknesses and sensory deficits of their legs and no facial droop. Recalling how motor fibers descend from the motor cortex to the internal capsule, decussating at the medullary pyramid and descending contralaterally down the spinal cord, we know that this patient will have deficits that are contralateral to the infarct as well. So, from the CT, we can tell that our patient will likely have motor and sensory deficits of the contralateral leg, likely producing a hemiplegic gait. A 55-year-old male patient presents today with the worst headache of his life. He denies any trauma and states that it started when he was doing his normal bench press routine today. Patient states that it has been a rough couple of weeks since he was in 2 minor car accidents. On exam, you notice that the patient has profoundly diminished peripheral vision during the confrontation test. There's no photophobia. The patient is a smoker and has hypertension. You order a CT and see this. So something that confused me a lot when first presented with scans of blood in the brain is differentiating between intraventricular and subarachnoid bleeds and what these mean. It's actually pretty easy when you see a couple and understand the ventricular system. The flow of CSF is from the lateral ventricles, where the CSF is produced by ependymal cells of the choroid plexuses. It then goes through the intraventricular foramina of Monroe to the third ventricle, through the cerebral aqueduct to the fourth ventricle. From the fourth ventricle, the CSF goes to the subarachnoid space through the foramina of Luschka and Magendie, or the lateral and medial apertures if you like. In the subarachnoid space, the CSF is reabsorbed by the arachnoid granulations into the venous system. So considering the flow of fluid, an intraventricular hemorrhage will have blood in the ventricles and a subarachnoid bleed won't. Compare this scan of an intraventricular hemorrhage with the earlier scan of a subarachnoid bleed. On the left, the intraventricular hemorrhage shows an enlarged and bright white lateral ventricle, while the subarachnoid bleed has blood in the subarachnoid space. So it's a good thing to note that it's always a possibility that a CT scan could miss a subarachnoid bleed. The most sensitive test for a subarachnoid bleed is a lumbar puncture, where you stab a needle in between somebody's vertebrae between L3 and the sacrum, into the subarachnoid space. So at the same time we're testing for blood, we are making someone bleed in the same place. So how is this test so sensitive? After taking the fluid from the spinal cord, the fluid is spun down in a centrifuge. The heavy red blood cells get pulled to the bottom, and the top layer, or the supernatant, will be clear in a traumatic spinal tap. In a subarachnoid bleed, though, some of the red blood cells will have broken, spilling their heme groups into the CSF. If enough time has elapsed, about 2 hours, then we can actually tell when this bleed started by what stage of getting broken down the heme group is in. You know what stage or how long the bleed has been going on by the color of the supernatant. When the heme is first released into the CSF, it gives a pink color. This peaks in 24 to 36 hours and subsides in 4 to 8 days. Heme oxidase then breaks down the heme to bilirubin, which is present 12 hours post-bleed, peaks in 2 to 4 days, and subsides in 2 to 4 weeks. The bilirubin has a yellow color. Alright, well, we covered testing. Now let's jump back to the pathogenesis of this case. There was no trauma, and he was bench pressing. So we can expect an acute increase in intracerebral pressure during the event. From the CT and lumbar puncture, we already know that he has a subarachnoid bleed. And although it's a pretty narrow differential for a clinic, on test day I'm only really thinking of a couple things that cause subarachnoid bleeds: trauma, aneurysms, and AV malformations. With no trauma, an increase in pressure before the bleed, and his history of smoking and hypertension, it seems likely that the patient ruptured a small aneurysm. Most aneurysms develop at the sites where communicating arteries meet other arteries. Here's a superior view of the vasculature of the brain, showing the posterior communicating arteries, and an anterior view showing the anterior communicating artery. The communicating arteries are small and don't have smooth muscle or internal elastic lamina. On top of that, at these branch points, the blood is making sharp turns and causing turbulence, increasing the pressure locally. Blood going through the anterior communicating artery would have to make two 90-degree turns. Consequently, this is where 40% of cerebral aneurysms happen. It so happens that we can localize our aneurysm to the ACOM. Our patient had a profound loss of peripheral vision. In medical speak, this is bitemporal hemianopia. The temporal visual fields both cross at the optic chiasm, then traveling on the side opposite of the eye that they came from. The classic question I think about with bilateral temporal hemianopia is a pituitary tumor compressing the optic chiasm. The pituitary lies just below the optic chiasm, and the anterior communicating artery is just above it. So we had a patient with an anterior communicating artery aneurysm from a physiological trade-off between collateral blood supply and turbulent blood flow compounded by vessel disease caused by hypertension and smoking, causing compression of the optic chiasm, causing a bilateral temporal hemianopia. His vessel then burst, causing a subarachnoid bleed, and now he's in big trouble. Subarachnoid bleeds are very serious and kill about half of their victims. After the bleeding is stopped, you still need to look out for hydrocephalus from clots, blocking any CSF flow, or from the blood blocking up the arachnoid granulations. Something blocking the flow is termed a non-communicating hydrocephalus, and a failure of the arachnoid villi is termed a communicating hydrocephalus. Another thing to look out for is vasospasm and rebleeding. A patient presents with a blown pupil on the left that is non-reactive to light without any other deficits. He denies any trauma. So what's going on here? The patient has an efferent pupillary defect. The efferent input is carried to the pupil by cranial nerve 3. But if he had a third cranial nerve palsy, wouldn't you expect him to have a gaze palsy as well? Not necessarily. The fibers that are going to the extraocular muscles supplied by the oculomotor nerve are carried in the middle of the nerve, and the parasympathetic sensory nerves are carried on the periphery of the nerve. An injury of one does not necessarily mean injury of the other. The motor fibers are much more susceptible to vascular diseases because they're deeper and have less blood supply, while the peripheral fibers are much more susceptible to compression. So what is it that's compressing his oculomotor nerve? Well, remember when we said that the communicating arteries are much more susceptible to aneurysms than the main arteries? The PCOM runs directly over cranial nerve 3, so an aneurysm can cause deficits of the parasympathetic oculomotor nerve while sparing the motor fibers. And this is one plausible explanation for our patient's symptoms.